This session is about the latest learning on livelihoods and child protection and well-being outcomes, and we have a truly stellar panel for you. And looking at it, I'm noticing that once again we have an all-female panel with a male moderator. We in any case, we recognize the wonderful power of women in research here. A reminder for those who want to follow the moderated conversation about social protection in Indonesia and the interaction of social protection policies with evidence. That conversation is happening downstairs in conference room 440. You would take the elevator to the 4th floor, turn a right out of the elevator, go through the glass doors, and it's the first room on the right. So I hope that some people have made their way down there as well. Josh Chaffin is the coordinator of the Livelihoods Economic Strengthening and Child Protection Task Force of the CPC Learning Network, a role that he has played for a number of years. It's a task force that is housed at the Women's Refugee Commission, and where Josh is a senior program officer. Before joining the Women's Refugee Commission, Josh worked at UNICEF headquarters, managing a global corporate evaluation of UNICEF's work with adolescents. He has also worked as a technical expert on adolescence at UNICEF's regional office in Nairobi and has consulted on youth employment and empowerment for the International Labor Organization, the UNDG, the UNDP, and a number of other organizations. Before all of that, Josh was a journalist, which is a really fascinating entree into this world of humanitarian affairs, and I'm sure he'll talk to you about it over the next coffee break if you'd be interested. Over to you, Josh.
Thank you, Mark, for the introduction. Much obliged, and thanks for throwing together such an amazing group of people. It's like a family reunion around here, and warms my heart a little to see everybody. So the task force, the CPC task force on livelihoods, economic strengthening, has been working for several years now to collect and share all the research that we can find on issues related to children's outcomes from economic strengthening, or really the economic dimension of child protection and child well-being. And we're also working to generate original research, some of which we'll hear about today, right now. The theme that runs through the presentations we'll hear today is they all relate to the economic dimension of child well-being, child protection, but they have three very different lenses on those issues. We're going to hear about experiences in Burkina Faso, in Colombia, and in Uganda. And I'll just introduce everybody at once. First of all, Laura Gower Bermudez is going to talk about the economic dimensions of antiretroviral therapy for adolescents in Uganda. She's at Columbia University currently, social work school, getting her PhD with Dr. Fred Sewamala, whom, if you know anything about children's outcomes from livelihoods work, you will have encountered his name. He's really important to my niche. And she's worked on child protection, gender-based violence, resettlement issues for IRC, World Vision, Department of Labor, and others, UN Women. So we're really happy to have her here. Joe Sanson and Leila Ismailova are going to talk about this randomized control trial that we're doing in Burkina Faso that's measuring children's outcomes from the graduation model, which is one of the few, if you don't know what it is, it's one of the few economic interventions that we know is effective at getting people out of poverty. So we were really interested to find out what are the effects on children. So they're going to talk about that. Joe is the global M&E research director for the US-based NGO Trickle Up, which focuses exclusively on serving the ultra poor. And she's got 15 years of experience in development, and I know for a fact that she's a super sharp thinker on M&E and evaluation issues. Dr. Leila Ismailova teaches at the University of Chicago School of Social Service Administration, and she researches on mental health, on violence exposure and risk behaviors affecting children and youth. And people like me keep dragging her into looking at economic questions as well as they relate to children. Finally, Dr. Sandra Garcia is going to talk about a meta-analysis of conditional cash that's looking at impacts on children, and crucially, it's looking at cost effectiveness as well, which is a dimension that very few of us who work on children ever get the luxury to look into. Managed to study. Sandra teaches at the Universidad de los Andes in Bogota, Colombia, where she researches child and family policy, education issues, and is also just a really brilliant creative thinker on research methodologies. So let's start with Laura talking about ARV therapy for adolescents in Uganda.
All right, thank you so much. As Joss mentioned, my name is Laura Gower Bermudez, and I'm a doctoral student and research associate at Columbia's School of Social Work, just down the street a little bit, a few streets down. What I'm going to be talking to you about today is equity and adherence to antiretroviral therapy among economically vulnerable adolescents living with HIV in Uganda. Dr. Fred Suomala sends his regards. He's in Uganda right now and is the one who, for the last decade, has been doing this very important work looking at financial inclusion and savings for vulnerable children, particularly in Uganda, but is broadening to other areas of sub-Saharan Africa as well. So I'm just going to start my presentation with a quote. It says, "When I first started taking ARVs, I learned I had to take them with food else I'd become nauseous. They also made my appetite too high. I felt hungry all of the time. I tried to eat more than usual, but the hunger I felt during that time was too much. I just didn't have enough food to satisfy my hunger, so I stopped taking my ARVs." And this is from a teenager living with HIV in Rakai, which is one of our study districts. So this quote and other information that we had read really led us to this research question of, we know that economic and social factors influence access to ARVs. We've known that for a long time. But in a place where access is now fairly easy, it's free, do these economic and social factors also influence adherence to life-saving HIV drugs? So what we did is we have a study design. It's called SUBI plus adherence. SUBI means hope in Luganda, a local language. And it is a 5-year randomized controlled trial that is funded by NIH. It's a cluster randomized trial that's looking at the effect of a financial asset intervention on adherence to ART. It's a 2-arm cluster design with 39 clinics and 702 participants. And the inclusion criteria for the participants is that the child had to be between the years of 10 to 16 years of age, prescribed ART, tested positive for HIV and knowing their status, living within a family, and enrolled in care at a participating clinic. So within this study, there's 39 clinics in 6 districts, and it's the random assignment was such approximately a little under half went to a control arm that received kind of a bolstered standard of care for what adolescents typically get who are HIV positive, and then a treatment arm, which was our SUBI plus adherence intervention, which was this family-based financial asset intervention that was implemented through a matched savings account. And this, just to show the study setting, is in Masaka, which is in the yellow region there, which is in the southwestern area of Uganda, that has quite a high rate of HIV prevalence, higher than the national average. So what we did is we took baseline data from this ongoing randomized trial. We're looking only at the baseline data, and we wanted to look at these issues of economic and social equity to see how they affected adherence rates at baseline. And it's in, just sort of fast forward, it's the full paper is going to be in the AIDS Care Journal in July. And so if you have an interest in this work, please look that up and you can read the paper in depth. But basically what we did is we took our primary outcome of analysis, our dependent variable, was self-reported adherence, the number of days in the last 30 days that an adolescent said they had not taken their medication the way that they were supposed to. And then we looked at a range of independent variables. What might influence an adolescent's adherence to ARVs? And we lumped them into 3 different categories. We had a category called assets and employment, which dealt with issues of financial inclusion, savings, employment in the formal labor market, tangible household assets. We kept that in kind of a category of its own. We had a category related to food security, number of meals per day, if breakfast was consumed the day of an interview, just a few food security questions. And then we also had a bucket on social equity, which was looking at access to services in the community, such as distance to school, distance to water source, availability of electricity, whether or not they were enrolled in school. And we added this other issue on social support. If adolescents said they had someone who was socially supporting them for adherence within their household. So what we did is we did a logistic regression, and we looked at these factors in a couple of different ways. We looked at each of the individual variables on their own to see what their influence was on adherence. And then we also looked at the composite or the bucket measures to see when everything was put together in a multivariate analysis, how did assets and employment affect adherence as a group? How did social equity affect adherence as a composite measure? So just to show you, just quickly to walk you through this table, this is a logistic regression. The OR column means odds ratio. The way that we set up this study is that if any of the variables were over 1, it meant that adolescents who had higher levels of relative advantage in any of those categories were more likely to self-report adherence. So you'll see the ones that are bolded and starred are ones that are statistically significant. So the two to note are asset ownership, which meant that those adolescents who had greater advantage in family asset ownership were more likely to self-report perfect adherence to their ARVs. And also down here in the bottom category, physical proximity to the health clinic. That one was also statistically significant. So for those adolescents who live closer to the health clinic, they were more likely to report adherence to ARVs. And I'm going to skip these slides for sake of time. It just is the text for what the results show. And then when you look at the multivariate logistic regression, this is where everything's kind of lumped together, and we want to see how the composite variables fare in terms of adherence. The first one I want to show you is our control factors, which are our demographic factors, age, gender, and number of HIV medications. While we only use them as control, one of them did come out as statistically significant for influencing adherence, and that was gender. Girls were more likely to be adherent than boys in this particular target group. And then the other one that's statistically significant for our composite variables here at the bottom are assets and employment. On a whole, those who had greater financial inclusion, greater household assets, were more likely to adhere to their medication than those who had relative disadvantage. Food security and social equity did not show association in a way that was statistically significant. So just a couple of discussion items from our findings. I think there's a few implications for policy and practice. I think that when we design an intervention, this is specific to HIV, but I think this has sort of broad applicability, is that it is important to look at the economic and social determinants of whether or not a child or an adolescent will take up a particular intervention. There's certain barriers to the take-up of interventions, and economic and social determinants should be considered. And also for this particular study, specifically, when we're looking at HIV treatment, we believe that interventions that aim to improve financial assets, that foster financial inclusion, and that provide geographically closer HIV treatment services, such as those through mobile clinics, will help with ARV uptake. I think one of the implications for research that we had was that this particular study is purely quantitative. It's crunching numbers, doing data analysis with baseline data. I think what would be important to do is to follow this up with some kind of qualitative work that looks at adolescents' experience of kind of relative advantage or disadvantage within their communities, and how that impacts their ability to avail of the services that are provided to them. And then just lastly, a couple of final things. When we look at gender, girls were more likely to adhere than boys. For this population, does that change over time as girls get older? They have more familial responsibilities. How does that change their adherence to ARVs? And then also, should we be doing something differently to target adolescent boys? Are they being left out of the picture in terms of uptake of these kind of public health interventions? Secondly, just about food security quickly, the way that we looked at food security, we only had a handful of questions that were part of our long multi-sectoral questionnaire for this particular project. It was not, a very comprehensive look at food security, and so if someone were to use kind of a long, more comprehensive look at food security, would the outcome be different? I'm not sure, but it's something to consider. I think that's sort of the first question. The second question there is, and this is sort of a broader development question, when we're doing these interventions that are aiming to have broad multi-sectoral effects on a number of different areas, how do we design our questionnaires so that they're not so long that they become burdensome to the people that we're trying to serve and that are our respondents? Is it possible to select a series of 5 questions in food security, child labor, maternal and child health, everything that we want to learn about? How do we do that without being burdensome to our respondents? So that's a larger question. We'll skip school enrollment and stigma for now, save it for Q&A for sake of time. And just in terms of the question of equity, I said I think that this particular intervention is specific to HIV treatment, but the concept of equity is something that's broad-based. How do we make sure that those, even within a vulnerable group, those who are most vulnerable, those who are kind of in the lowest quintile, the lowest 20%, how do we ensure that they are able to avail of the interventions that are provided to them? And that is it. Just a quick acknowledgement of our donor, the National Institutes of Health, NIH, the publication co-authors, and also our fantastic research and implementation support team in Uganda, which is made up of a great group of young Ugandan researchers that are making all of this happen. So thank you so much.
And thanks to you, Laura, for that. There's just so much of what we know about this subfield is being generated by you and your immediate circle of colleagues. So thanks a lot for all that work that you're doing. Remember when we used to wonder if economic strengthening interventions would have effects on outcomes for children? We're starting to see lots of different categories, really interesting positive effects, which is a great place to be in history. Sandra, can you talk to us about your meta-analysis of conditional cash programming?
Hi. This presentation is maybe it's very different from what we've seen in these couple of days. And I think that the common thread is outcomes for children, and trying to summarize 10 years or more of research made worldwide from different countries and different authors all over the globe. Maybe for this audience, this is not necessarily, but I just summarized what CCTs are. Conditional cash transfer are subsidies, monetary subsidies that are provided to low-income households, usually conditioned on 2 things. One is enrollment of children in school, and second, for children that are between 6 and 11 or 0 and 11 to go to regular health checkups. In addition, some countries, as we will see in a minute, have additional conditions. In one of the regions of the world that was a pioneer in this program was Latin America, starting with Mexico, and with a main objective to make this as the strategy to break the cycle of intergenerational transmission of poverty and through the building of human capital. And if you can see on this map, the latest count that we have is that we have 78 CCT programs in 49 countries around the globe, mostly virtually all countries no, all but 4 countries in Latin America have CCTs programs, and Asia and Africa also have CCT programs going right now. So the question that we had with my colleague, which I didn't acknowledge, is with Juan Esteban Saavedra, who is at USC, is now that we have this huge expansion of CCTs as a means to break intergenerational poverty, we did have or have previous evidence on rigorous impact evaluations of these CCTs around the globe. Many impact evaluations, most of them RCTs, measuring tons of different outcomes, both in education and health. Most of these were are suggestive of positive effects on schooling, but there are to date not studies looking at quantitatively what's the if these effects are large or are not large, first of all, and second, what are the characteristics of the programs, if any, that are associated with larger effects, so that we can learn and draw some conclusions on this evidence. So our paper, what does is to integrate in a quantitative way all this evidence that has been produced, and we focus on 3 main outcomes: enrollment, attendance, and dropout, not because they're necessarily the most important ones in education, but is because those are the outcomes that have the most number of evidence or number of papers that we can draw into our meta-analysis. What we did is that we searched all countries that had CCTs using 3 main broad databases. One is the World Bank database on CCTs that was drew upon Ariel Fishbane and Norman Shaddy's review of 2009. We also used CEPALS, which is a think tank of Latin America. They also have a database of all CCTs in Latin America. We also used Africa Cash Dividend that has a very thorough review of all the CCTs in Africa, and Sarah Bird's review on CCTs and unconditional cash transfers, both in different middle and low-income countries. So our strategy was to first look at all countries that did have a conditional cash transfer program, and then look for an impact evaluation, either if it was published or not published. And if it was published, obviously we got to the publication. If it was not, we contacted the PI or the researchers that were conducted the impact evaluation in order to get the report. Then for each study, what we did was to select the best effect size, which was like the most robust effect size that the study reported. But basically, most of these studies were RCTs. So the most robust was the difference between control and treatment group. If it wasn't a randomized control trial, then the most robust in terms of having the cleanest estimation. And most importantly, we collected as much as possible, as we could, contextual characteristics of the country and of the program. So whether or not the program provided additional support, like supply component, whether or not the program conditioned on other behaviors like achievement, the subsidy amount, etc. We also rated the studies according to a quality rating criteria based on what works clearinghouse protocol, and I won't go into the details, and I will happy to talk on the questions if you have questions. But basically, the criteria were based on whether the study was randomized or not, and if it wasn't randomized, if it used econometric techniques that are internationally or standardized as clean estimations. So I'm going to jump into the results. So out of the 78 programs that have CCTs around the world, 46 of them have impact evaluations. So our meta-analysis includes these 46 studies. More than half of them, 26 of them are in Latin America, and the rest are distributed in different parts of the world, including obviously Africa and Asia. It's important to say that we're only including middle and low income countries. We're not. That's why, for example, the United States is not in this table. As you know, here in New York, you have a CCT program. Most of them are conditioned on enrollment or attendance, and close to a third of them, 14 studies or 14 programs, condition in addition to enrollment to grade promotion or achievement. They are equally distributed in terms of the payment frequency. 10 studies or 10 programs make the payments monthly, and other 20 of them make the payments bi-monthly. The average subsidy is around $21, $2,015 per month per child for primary school, and $24 for secondary school. And most of them, in 43% of the studies, is the guardian or the parent who receives the money, and in 37% of the cases is the mother or a female guardian who receives the money. And only 5 programs have a supply supplement or a component. For example, an additional grant to the PTA of the school or an additional grant to the teachers. This summarizes the effects of the studies on primary enrollment. So all the dots are, each dot is an effect size. All of them that are at the right are positive effects, and if the lines do not touch the vertical line, is because they're statistically significant. So as you can see, most of them are positive and are statistically significant. That's something important. In terms of the size, the diamond at the bottom is the average effect size, which is 3 percentage points. Which is, for a baseline enrollment of 83%, is not that large. It's about 5% of an impact. For secondary enrollment, the effect is much larger. It's 7 percentage points. For an average enrollment of 51%, is a larger effect. It's more than close to 15% of an effect. So the effects are substantially larger for secondary enrollment. I didn't plan my time correctly, so Jeff is saying that I have 1 minute. Okay. So for primary attendance, the story is very similar. We have larger effects in secondary than in primary. Second, we have a lot of heterogeneity. So there are countries that are programs that are doing much better than others. And I'm going to skip the dropout rates to give you I think one of the most interesting things, which is to look at what characteristics of the programs are associated with larger effects. So the subsidy amount is positively associated with larger effects in primary enrollment, but not in secondary enrollment. So larger, more investment or more larger subsidies won't make a difference in larger enrollment. Also, payment frequency, further the payment frequency was negatively associated with effects. So that talks to budget constraints at the household level, again, for primary and not for secondary. Surprisingly, conditioning on achievement is not associated with any changes in enrollment. I see some nodding, but it was surprising. We thought that we were going to find larger effects, and we didn't. And also, for the supply component, we find a positive association with those programs that have a supply component have larger effects in primary, but not in secondary. In secondary, actually, there is a negative association, which was also a surprise. There's 1 minute left. Let me just go back to the enrollment baseline, which is important, and is that for secondary enrollment and attendance, CCTs are particularly effective in those countries where baseline enrollment are very low. So to conclude, I'm skipping this one that is about the cost effectiveness, and the story is basically the same in terms of the characteristics that are associated with more or less cost effectiveness. And to conclude, CCT programs are particularly effective at improving schooling outcomes in contexts with very low baseline secondary levels of schooling. As I said, the supply component has larger effects in primary schooling and not in secondary schooling, which draws a lot of lessons in terms of how to build better designs of CCTs if we want to increase enrollment and attendance in secondary schooling. And also the transfer amount and payment frequency are associated with larger effects in primary but not in secondary schooling, which also tells us about some necessary redesigns to target to adolescents and children enrolled in secondary schooling. So basically, this is just summarizing a lot of evidence that has been built in these 10 years. The idea is to use all these summaries, not to run more RCTs on cash transfer programs. I think we're not going to get any new information, and it's what can we draw from this information in order to build other programs that can make the further step in terms of getting adolescents and children in secondary schooling to graduate and to move on into better educational tracks.
Great, thank you so much. It strikes me that we're really starting to understand what we know and what we don't know about in this field of understanding children's outcomes from economic strengthening interventions. So Sandra's just reported on a meta-analysis looking at gold standard research on conditional cash, and then Innocenti, Tia Palermo and her colleagues at Innocenti have one on unconditional cash, if I'm getting that right. And then we did one, CPC did one recently looking at all the economic interventions that are not cash. So we kind of know pretty well what we don't know now. Lucky us. Anyway, so to try to fill some of the gaps that remain, I am extremely proud to present Layla and Joe, who are going to talk about this RCT that we've got going in Burkina Faso. It's definitely the best piece of research that you're going to hear about the entire time you're here, because I'm involved with it. No, because I'm really happy that it's happening, and we're finally getting findings, and the findings are really exciting. So without further ado, Joe Sanson from Trickle Up.
Okay, thank you, Josh. So I'll be co-presenting with our research partner, Layla. But this is it's an evaluation of our program in Burkina Faso. Now, as Josh mentioned before, I work for Trickle Up, which is an organization that works in Africa, Latin America, and India, promoting the graduation approach, which is an approach that for now there is a very strong level of evidence about its ability to sustainably move extremely poor people out of poverty. But of course, as we know, to really make sustainable changes around poverty, you've got to break that intergenerational cycle. So we've been very interested in this question of what are the impacts on children, for which the evidence base so far has not been very conclusive at all. And what are the ways in which we can strengthen our programs to enhance those impacts for children? So we embarked on this evaluation in partnership with Layla from the University of Chicago and Josh at WRC, which started, for now we're going to be presenting on some of the year one results. So one of the reasons why we chose Burkina Faso was because we were seeing a number of particular risks there for children. Now, of course, we see them in all these places, but there's some specific concerns there. I must say as well, one of the other reasons why we were interested in doing the evaluation in Burkina Faso was because the program learning group, which was being set up then, and Al Gassamou and has been a great help for us in this evaluation as well. Sorry. So Burkina Faso is it's among one of the poorest countries in the world with very high levels of poverty and food insecurity. And we're doing our evaluation in the northern region of Burkina Faso, which is one of the 2 poorest areas in the country. It's high that the main risks that we're seeing around violence and exploitation, particularly separation of children from their families. A lot of this is to do with work. There's proliferation of artisanal gold mining in the region, for which boys in particular are going off to work in. But then there's also a whole number of factors related to extreme poverty in itself within the households, in terms of the tension that it creates within the households and the lack of food security and so on. And interesting, we had a qualitative component to this as well, and a lot of the people in the households were actually saying when they think about violence, they really think about that lack of food and that anxiety about it as being part of it. And the other reason as well is, as I think sort of Josh has mentioned, is that a lot of these reviews show that there's really inconsistent evidence about the effect of economic intervention. So we're really wanting to contribute to that evidence base. So the aim of the study was to assess the effect of what is largely an economic empowerment program. Now, the graduation approach, I'll go into that more in a minute, but it's largely focused on economic empowerment, but also to look at the additive impacts of a component specifically focused on child protection. While a number of our programs already had some elements of this, it wasn't hugely systematized. So our basic program, as I mentioned, is based on the graduation approach. It has a number of key components: savings group formation, which is important for both financial and social solidarity, livelihood planning and training, seed capital grants to jumpstart activities. And again, it's important here, we're working with people who are generally considered too poor for microcredit, so it's important to provide something to get them started, and regular coaching and mentoring and support by field agents. The economic, the sensitization component was specifically around the main risk factors, which I've mentioned. Some of these around cultural beliefs related to children, including attitudes towards discipline, importance of education, again, important gender component here related to girls, and risks about children being sent away from home, and also early marriage. And the economic strengthening, the sensitization component was done at both the group level and at the household level, in partnership with our local organisation, ADIFAD in the north, which has a big focus on child protection issues, but also did include a fair bit of case management, where the field agents would go in if they were seeing issues they would follow up on. And here I'll pass over to Leila.
Okay, so I'll talk about the conceptual model and the methodology and results, and Joe will continue with the discussion. So as it was mentioned, first we wanted to test in this evaluation study whether it's the economic, whether it's family-related poverty that is leading to this child protection issues, or whether it's something else. So therefore, we were not just limiting it to economic intervention. In the second arm, we added this child protection sensitization component that looked at factors related to normative beliefs about child protection, where we didn't work just with one woman, we worked with the entire household. And the idea was to see if there are going to be any outcomes on children, everything related to family separation due to work, marriages, to violence, exploitation, and then overall to child well-being. So in terms of methodology, we selected the 12 poorest and comparable villages in the North region. We conducted a household wealth ranking exercise, and based on that, we selected poorest of the poor households. So these are ultra-poor households in very poor villages, right? And we selected children at between any family that has a child between the ages 10 to 15. The reason we chose this group because they're at highest risk for child protective issues, everything to getting married early or going and working away from the family. But also we wanted to have reports from children, and we thought that this is the age group where they would be able to provide the report. But we also interviewed mothers, and they provided information for other children that are in the household or away and that are younger than that. So we have reports from both sources. So this is quickly study design. It's a cluster randomized trial, meaning that we randomized people to groups based on villages. And we did it on purpose because we were told by the local community, if we're going to give one family economic intervention and we're not going to give it to another family that lives next door and we just say it's random, it would be very hard to explain why, right? What makes it different. So therefore, we really did randomization by villages, and we had 3 groups. One is the wait list. The ES, it's the economic strengthening that received only economic intervention, and the last group received both economic intervention for women plus the child component sensitization for the entire household. And we had fairly good retention rates, and at the moment we will report results at 1-year follow-up, and we're really hoping to conduct the 2nd-year follow-up as well in the future. So we collected data both from mothers and from children. We did it in Mura language, and we were using local students from the University of Ouagadougou, from the Department of Psychology and Sociology to help us conduct those interviews, and we kind of helped them train. In terms of results, you'll see probably more if you want. I can come back at some point, but I know we're always, pressed on time, so I'll just go quickly through this. So overall, we had kids about the age of 12. About 60% go to schools, about a quarter don't go to any school, and about maybe 15% go to religious schools. And here we combine both madrasas and Quranic schools. This is a Muslim community, so it was fairly homogeneous. About 40% of families lived in polygamous marriages. These are fairly poor households, so as I mentioned, none of them had electricity, but surprisingly about maybe 40% reported having a cell phone. So that's just kind of for future programming if we ever need to. And they experience severe hunger, meaning like they go without food either for the entire day or go to bed hungry or skip meals. So this is just briefly to report from the baseline what kind of childhood adverse experiences that kids reported, and you see numbers separately for girls and boys. Even though we were expecting to see huge numbers for kids who are working or working away, we actually or experience abuse at work. We actually see much higher number for abuse within the household, right? So either physical or emotional, and in terms of gender differences, we didn't see any major gender differences except for maybe a couple of variables. One, we do see that girls work more, both for their own household, doing household chores, but also doing any other kind of economic activities. And they're also getting paid less. Kind of nothing surprising there, but it seems the story is the same in many places. So in terms of intervention outcomes, so first I'll start with economic. And you see the results reported first is the economic intervention alone. That's the group 1, the treatment group 1. And the second column, that's treatment group 2 that received both economic and child protection. So the first section looks at household assets. As you can see, both groups performed pretty well. We do see significant increases in the number of household assets, and that's everything from having, what do we have there? A number, okay. We'll go into that. I'm blanking it at the moment. Then we looked into savings. We also do see significant increases in both groups, fairly similar in terms of the savings amounts that women reported having. So it's close to about $50 in the US dollars. Because it wasn't just the savings, group savings, but it's also when they're investing money in livestock values. So we also saw similar increases in both groups. And also expenditures on children, and that includes everything on health-related educational expenditures. So those results are fairly similar for both groups. In terms of food insecurity, we asked both children and mothers. So for mothers, we see that food insecurity reduced, right? That means they were reporting less being hungry than before. For mothers, we see in both groups. For children, you see only in the second group. And I'll come back to those results because that's where we start seeing different results based on group 1 and group 2. Right? Once it comes to outcomes for women, if you remember from the conceptual model, strengthening women's empowerment status through economic empowerment was one of our kind of proposed mediators and mechanism of change. So we wanted to see, are we able to make any changes, not just at the financial status that the woman has, but as it change her status, how she feels in the family, what she's able to do. So in terms of empowerment, we saw women reported being more financially autonomous, and the results are significant again in both groups. They reported having ownership of household assets. Not that there is a, let's say, phone in the family, but she owns one too, right? And then we also saw what was quite interesting and probably could be quite encouraging for spouses is that there was an improvement in the quality of marital relationships, right? They felt that they were more respected, the husbands were more affectionate with them, and they were talking to them more, etc. We also included outcomes for domestic violence because we saw there were a few RCTs in sub-Saharan Africa that were reporting that once you empower women economically, it may actually increase the rates of violence in the family, and that often served as a barrier. So that's why we included this measure, and surprisingly, we actually saw reduction in violence, at least emotional in both groups, and in physical violence in the group that received not just the intervention for women, but where husbands were also involved. So that's, I think, is quite interesting. And as a result, we also measured women's emotional well-being by using, depression and anxiety level just to measure kind of as a proxy for her stress. And we saw, again, a reduction in both groups. So now, once it comes to child outcomes, if you remember, the intervention mainly targeted women, and it is not surprising that we see changes at the level of women. But once it comes to child results, for the most part, we do see changes only in the intervention that was combined, economic plus the child protection component. So we ask mothers whether their kind of beliefs and norms and attitudes, if it's okay to hit a kid, if it's okay to send child to work away, or be a migrant kid, or early marry, or get married early. We saw that mothers started having more positive and more kind of a child supportive attitudes in the second group. They also reported using less harsh disciplining practices. And as a confirmation, we also saw that physical and emotional abuse that was assessed through kids, we also saw a reduction in physical abuse in children, only in the second group. And what's interesting, we only saw it in non-polygamous households. And again, our explanation is because we didn't, for each family, we only identified the poorest woman in the household, and we intervened only with her. So therefore, we probably saw changes only within that micro unit. And we didn't see changes in polygamous household, we didn't see changes on the entire family because they were just not involved. And we also, therefore, as a result, we also saw changes in kids' emotional well-being. They reported feeling, lower levels of depression and higher levels of self-esteem, but primarily among the younger kids. So, and I will pass on for discussion.
Okay, so I'll be very quick here because we're a little over time. But basically, these results more or less confirmed our hypotheses that the economic interventions were indeed having positive economic outcomes. They were improving women's status in the household and their well-being. But there weren't that many impacts on children. There were some around food security and so on. And I should say this is, these are still fairly short-term outcomes. This is just after 1 year, and we are looking for funding to fund the second-year follow-up as well. And what we are also seeing, though, is by adding that child protection component, it does actually have that significant added impact on child protection outcomes, including on the way that the households are actually using their extra resources for children. And this is important, and it fits in very well with the graduation approach, where there already is this case worker model, where there already is follow-up to the household. So it's actually a fairly easy thing to integrate into the program. So that's obviously something which we're going to be replicating within our sort of future programs and also our work with government social protection programs. But as Leila mentioned, it is important to note as well that these impacts on children are stronger in these non-polygamous households. And so it is still a challenge for us to determine how do we make these programs work best within polygamous households. And that's something which we're continuing to work on. We're not reporting on the qualitative evaluation here, which is also very interesting, but hopefully some other time we will manage to do that. But just let me quickly acknowledge our funders. Our primary funder is the Children and Violence Evaluation Challenge Fund, as well as some support from the Child Protection Working Group of UNICEF. And they're, our co-investigators as well, Leila Karimli, and others. So thank you very much.
Thanks so much to Joe and Leila. And we have 10 minutes for questions. But just to recap, a takeaway from the study so far, as I understand it, is don't do your economic strengthening program without some kind of child protection component. Not only because you're seeing deeper effects of your economic intervention with the child protection component, but also because we just did like I just mentioned, we just did a meta-analysis of economic interventions around the world, measured, gold standard measurement, and we found that a full 20% of the studies found economic interventions doing harm to children in some form, usually with regard to education and enrollment, or the flip side of that being child labor. So yeah, there's every reason to add child protection programming to your economic intervention. I will stop talking and you can ask questions. And Alina's got the microphone, so wait for Alina.
You want to call on people, Josh?
No, you go ahead.
Okay.
Okay, thank you very much, and I appreciate the presentation. It was very interesting. I don't have any question, but just a comment according to the presentation for Burkina Faso. I would like to say that that research was very interesting for us in Burkina Faso, because it was the first research I know in Burkina Faso which focused on what we can obtain by helping families on economical situation, what will be the impact on child protection system. Yeah, I don't know if you understand what I want to say, but all the stakeholders in Burkina Faso are really waiting for the result, because we try to convince the donors that you cannot give a good protection services to the children without helping their parents. Because in Burkina Faso, I think the statistic situation said that more than 65 children are really living in poor situation. So if you want to give them services like education, health, you can provide the services that can help them for a moment. But if you don't try to help their parents to improve their income generating activities, you can't have any impact for a long time. Thank you.
Thank you very much for George again from CDC. Thank you very much for that enriching presentation from all of you. My question goes to the conditional cash transfer, basically in the context of East Africa. I've just observed some variance between Tanzania and Kenya, and it looks like all the data shows it's on the left-hand side, okay, in most of the outcomes. It brings me to the point of thinking in terms of Uganda. There was data that indicated that conditional cash transfers have little influence on HIV prevention among adolescents and young girls. And Dreams wanted to use, we thought we'll use conditional cash transfer in Dreams, but because of evidence, we were forced to do a pilot, and we are going to do a pilot in Rakai, I think, to see whether we can twig it and see whether it works. So I just wanted to know whether you have, you really tweaked, whether you could do a further analysis and find out the factors that made cash transfers in Kenya and Tanzania not successful, fail or succeed, so that we could learn from that and maybe think of how we could implement such a program within Uganda, especially in the HIV context, HIV prevention context.
All right, we'll just take those two questions, and then we need to do the answers because we only have 5 more minutes. Make your questions very brief.
Thank you for the fascinating presentations. I think my 2 main questions are about the intervention in Burkina Faso. So you mentioned adding a child protection component, but we've also seen reductions in violence against women by adding a gender component as well. You didn't really mention whether there was gender sensitization involved, so I'm wondering if there was gender sensitization involved in gender-based violence information, in the child protection component, and whether you're considering in the future adding information about like just women's equality or gender equality in general. And then thinking about the polyamorous and non-polyamorous difference, I was thinking about the secondary analysis of IRC's EASE program and how they showed that there wasn't actually a lot of impact in reducing violence in that combined economic and gender sensitization intervention among women that had been married as children. And so thinking more in like a more nuanced way, I guess, in general about how there are relationships and marriages and ways of approaching these interventions that we may need to think about differently, and whether you're finding it's a different situation, but whether that might be connected at all causally. And I will leave my other questions because I'm running out of time.
Hi, I'm Ken Goody with the Dorothea Ross Foundation, and very quick question. Thank you very much for the presentations. This is a very general question, as you might expect from a funder. I'm wondering is, as this data is become more and more known, the effect, child-level impact of economic programs, particularly livelihood programs, are the larger agencies and others actually incorporating as a best practice child protection work in their economic strengthening programs? General observation.
Answers to the question, the wonderful questions we've been getting?
So thank you for your question. I'm sorry I don't have the specific answer, and you make me go back to the data and look for the specifics of the design in Tanzania and Kenya. One thing that draws from other CCT programs that have negative effects is that sometimes the targeting is only to one kid of the household, and then the decision of the household is to invest just in that kid and not in others. So maybe it has to do with how the targeting within the household was made, but I don't have the specifics of those two countries. But I hope to dig in the data and have an answer for you quickly.
Yeah, thanks for the questions. In regards to the question around the impacts on women, our program in Burkina Faso didn't have a very significant component focused on women's well-being. We have integrated those in some of our programs in other areas. Now, that said, the social solidarity that comes through the savings self-help groups is something that's important, and it is a forum in which the women do often discuss these issues related to the issues they have in the household and so on. But certainly that is one of the other issues that we are looking at as we, sort of assess these results and so on is, other sort of program design modifications to further strengthen the impact on women, and that's certainly one of the things that our qualitative researchers in Burkina Faso were recommending as well, because they were saying, look, we're seeing some really positive outcomes in this regard, but there's ways in which we can probably make it a little bit more explicit as well. Yeah. Sure. You can do it.
Yeah. So I think the only moment when we discuss gender issues is in relation to the child. So there was a whole component on importance of education for girls and like everything that's related to that, but not specifically to mothers, but
and around marriage and so on.
Yeah.
And the sense we got was by talking about issues around violence and so on within the household, that also did sort of open up more space for discussion around sort of gender-based violence and so on as well, even though that wasn't the primary motivation.
Hey, can I ask a question? Laura, you said that girls are more likely to adhere to ARVs than boys, but I was wondering if there are differences by sex in terms of the intervention effect. And now that I've asked you the question, you have like 20 seconds to answer it.
Well, it'll be a very quick answer because the work that I presented was solely on baseline studies, so we're just now getting treatment effects in from the first year. But we'll definitely be looking at that, and I'll be sure to email you once I find out.
Speaking of which, if you are doing any kind of research on economic interventions or economic dimensions of child protection, child well-being, you have a moral obligation to share it with me so that I can share it with the rest of the world, because that's what we're here to do. Sure, want a last comment?
Yeah, very quick last comment, I think, to really answer or maybe comment on the issue from the funder in terms of what's the message for the larger level donors? And because usually I don't hang out as much with people who do kind of economic development research and who are more involved in like kind of parenting interventions and prevention interventions for families, then in that world, I'm trying to convince them that when we work in low resource setting, it is, before we introduce this kind of interventions, it is really important to address poverty-related issues, right? But when I am with the group that does most of the economic research with families, right, I'm trying to convince them that it is actually important to not only provide economic strategies to families, but also address all other factors that affect how we treat kids, because it's never just one issue. We do talk, I think, a lot about that these are kind of have multiple factors. So I think probably the message is that maybe we need to test more models that are integrating, and maybe that's when we start seeing different results, because I think systematic reviews or meta-analysis that we were presented or mentioned today show that there is a great variability in results. Some of them work, some of them don't, and I think it's really more of like, how do we now use this model and try to integrate it with other good interventions that are working? So I think that's kind of the message for me.
Okay, we'll leave it there. 1 or 2 minutes over time. But thank you so much to these panelists for their discussion. And I have the task of, we're going to go to coffee break now, so you can feel free to get your coffee. But during the time that we're having our coffee break, I'm going to give a plug for the reintegration guidelines that have just come out.